Hey, good morning.
Morning.
Hey, Frank, I assume you want residents up.
Sorry, what'd you say?
Are you looking for residents to be on the panel?
Oh, yeah. Yeah. Do you guys mind raising up the residents?
Just keep this up for a minute or two while everyone's signing on, but please remember to start logging your attendance so you can get your 2023 CME credit.
Recording in progress.
I'm ready whenever, Dr. Morrison.
Looks like we have a good number, so I'll take this down and we'll go ahead. So we're gonna start with spine conference today, and then I'll introduce Dr. Kellner for his talk. So Frank, you're running spine conference today?
Yeah, I'll just find conference there. Yep.
Perfect.
All right. Sorry, 1 second. Let me share my screen. Just full screen it. Are you seeing my? Yeah. Yeah, you see. Okay, great. All right. Good morning. I'm Frank. I'm one of the chief residents. So I just finished my 6 months enfolded spine fellowship here with the neurosurgery service, and it was a really incredible experience. I thought I'd highlight some of the more challenging cases that I did during those 6 months. I think the beauty of spine is that, I think different attendings here will see these different cases and then come up with a different alternative plan or a construct. And so I think that's one of the best things about spine is that there's not one single perfect answer for some of these cases. So I guess I'll go through my first one. So this is a 72-year-old female. History of CAD. She had 2 stents. She had a prior, most importantly, she had a prior C2 to T2 fusion. And she was brought into the emergency room after a fall 2 weeks ago, hitting her head backwards. Initially, she said she was fine and neurologically intact, but then developed progressive onset weakness. And so her exam, when we examined her, her uppers were diffusely 4 out of 5. Her left lower was not anti-gravity. Her right lower was anti-gravity, but just barely, and her sensory was decreased throughout her entire whole of her dermatomes. So I guess we'll start with interns. Chi, can you help us read this CAT scan here?
Yes, so we're looking at a sagittal view of the cervical spine. It's a CT scan. And from looking at the rightmost panel, we can see the fusion construct that she had. And it looks like, so she has diffusion. It looks like from C2 to T2. And I can see that the spheres are either intact and possibly there is looking at the leftmost panel, it looks like potentially the rods itself might have been having some bending in it. So I can't see a clear breakage.
All right, so I'll tell you that the rods are intact. How about at C2? What's going on here is she has a pars fracture here on the right side, and that's encroaching into the, and it's going through the transverse foramen here, where the vertebral artery exits. And you can see that there's superior displacement of the pars up, which is blocking the C2 foramen here under the posterior ring of C1. And then here in the middle panel, you can see that she has a type 2 dens fracture, which there's anterior displacement of that fractured dens. You can see that this used to be one piece, but because she hit her head, she fractured this point above. Okay. All right. So what's our next step? And after we see her, we get we got that imaging. What's the next set of imaging you want?
So I want an MRI of her cervical spine, and I want to make sure that she's immobilized in a collar. Great.
So we put her in a collar, MRI. What's a different imaging modality that you can get while she's still on the table getting her CAT scan?
I might want a CTA, looking at the arteries as well.
Great. So we got a CTA of the head and neck to rule out a dissection, and then we got an MRI cervical spine like you asked. So here's the MRI. Here's a CTA on the left. You can see. Can you see my mouse?
Yeah.
Okay. So here's the right vert here, and here's the left vert here. She has a left-sided dominant vert, luckily, and there's no dissection. And you can see that on the MRI, she has severe core compression at C1. All right. So we'll talk about C2 dens fractures quickly. So these are odontic fractures. They're most commonly seen in the elderly. They're generally low energy impacts. If you find them in younger patients, it's generally high energy traumatic injuries. It's the most common fracture of the axis, and it accounts for 10 to 15% of all cervical fractures. We see them pretty commonly at Elmhurst in the elderly. And let's see, Emily, the mechanism of injury. What are the two types of injuries? Like in general, you don't have to say like, oh, like it's like a motor vehicle accident, but how does this injury occur? A type 2 dens fracture or type dens fracture in general?
So definitely like trauma is a common cause. So fall onto the head, especially.
Okay, I guess I'm playing read my mind, but what I meant was so hyperextension is the one mechanism of injury. It generally leads to posterior displacement of the dens because the anterior ring of C1 pulls the dens back during hyperextension. And the other one is the opposite, which is hyperflexion, and generally leads to anterior displacement of the dens and associated with transverse ligament failure and atlantoaxial instability. And this is probably what our patient had. She fell, like she described, she fell on the back of her head, which probably causes a flexion injury. And she has anterior displacement of the dens. And it's just a picture depicting those three things, or two things rather. And then, so this is often confused with os odontoideum, which is a floating C2 dens. And the etiology is controversial. It's still up in the air whether some people believe is embryologic versus developmental, or whether it's post-traumatic at a young age and just heals in this fashion. But you shouldn't confuse this because there's oftentimes good sclerosis and an obvious distance between the dens and the body of C2. All right, so we'll go over some O to C1-2 ligaments. So start at Chi. What is A?
Is that the apical ligament?
Right, apical. B?
There's an alar ligament.
Alar ligament, nice. C?
Transverse ligament.
Transverse, nice. And then D? This one's the tricky one.
I'm not sure about that one.
This is the accessory atlantoaxial ligament. And then D, sorry, what's E?
Yeah, I'm not sure about that one.
inferior longitudinal bundle. But nice job. All right, so then we'll continue with the ligaments here. Emily, what makes up the cruciate ligament? You're muted.
Sorry, you got the superior longitudinal.
Great. The superior longitudinal band, which is separate from the apical ligament way back there, the transverse ligament, and then the inferior longitudinal band. That makes up the cruciate ligament. So, and then what does the transverse ligament connect? Emily?
Is it the transverse process of C2?
Very close. The posterior odontoid to the anterior atlas. So it holds the dens attached to C1. And it's the primary stabilizer of the atlantoaxial junction. So this is sometimes better seen in the sagittal view. And you see there's the ALL above here and at the front. You have the apical ligament, which is separate from the cruciate ligament, which is made up of those ligaments that we're talking about. And then the tectorial membrane, which becomes the PLL down much lower. And so then finally, so we have this posterior view. Let's see, Brandon, what's A? Then? Oh, Brandon can't unmute. Okay, Noah, what's A?
Hey, can everybody hear me?
Yeah.
Pectoral.
Pectoral membrane, nice. What's B?
Looks like these are none. I think it's the alar that's directly anterior to it. I don't think that they're connected.
The alar is going to be way anterior to this. What's going to be lateral to it? It's the accessory membrane that we're talking about. Okay. And then finally, C is going to be what?
Posterior. Posterior.
Correct, yellow, nice. All right, and what does the tectorial membrane connect? The posterior body of the axis to the anterior foramen magnum. All right, so we could look at the blood supply of the dens, and where does the blood supply come from? Let's see, Matt.
I'm also not familiar.
Oh, Dr. Morrison or Dr. Morrison or Dr. Kellner, can you promote Brandon and and Matt Carr up? All right, so let's see who is next. Halima, where does the blood supply of dens come from?
From the vertebral artery.
Okay, that's part of it. So the apex is supplied. Yeah, exactly. Yeah. So the apex is supplied by the branch of the internal carotid, and the base is supplied by a branch of the vertebral artery. And so this is part of the reason why people think that type 2 dens fractures have poor healing, because the watershed area between the apex and the base. And then you can see here the branch of the internal carotid, branch of the vertebral artery feeding the apex and the base, and then the neck where you have type 2 dens fractures, usually a watershed area. And so we classify type 2 dens we classify dens fractures generally using the Anderson and DeLonzo classification. And type 1 is an oblique fracture at the tip of the dens. And the mechanism of injury usually is an avulsion of the alar ligament. And we should rule out atlanto-occipital instability with flex X-rays. And this is what a type 1 fracture looks like. Type 2 fracture is a fracture through the neck of the dens, and a type 3 fracture extends through the cancellous body of C2. And then so management of these fractures. And so which one of these fractures can be managed in a hard collar? In general, type 1 can be managed in a hard collar. Type 2 in the elderly who are not good surgical candidates can be managed in a hard collar. Oftentimes it leads to a non-union or a fibrous non-union, but this is considered somewhat metastable. And as long as the flexion extension x-rays are stable without symptoms, you can continue to manage in a hard collar. And type 3 can often be managed in a hard collar as well. It's typically worn 6 to 12 weeks, sometimes longer, and you get serial x-rays with close follow-up in your outpatient setting. And so who can benefit from halo immobilizations? There are a handful, but the usual suspects that can, patients that can benefit from it are type 2 and a young patient who you don't want to take away their C1-2 movement, and they have good chances of fusion, autofusion on their own. but who can't tolerate halo immobilization? These are usually elderly. You take away their OC movement and C1-2 movement, and they have very high risk of aspiration, pneumonia, getting pegged, and much higher rates of mortality. This has been shown in literature many times. And so, what are our operative options? The ideal candidates for C1-2 fusions are type 2 fractures with risk factors for non-union, type 2 or 3 fractures that have failed conservative management. These are the ideal candidates for C1-2 fusion. And so, what about an anterior odontoid screw? Is that a good option for our patients? We'll go over why not. And so, for an anterior odontoid screw, generally, the ideal patient is a type 2 fracture with risk factors for non-union, but they have to have acceptable alignment, or it needs to be easily reduced. So an anterior oblique fracture, like you see on the right, is ideal, where a fracture line is perpendicular to the screw trajectory, which is going to be from the bottom of the tip, the anterior tip of the dens, and it's going to go C2, and go through and through the dens here. It's not an ideal screw for anteriorly displaced fractures like our patient who have had hyperflexion injuries because the dens fragment that's fractured is anterior to your starting point, so it would be very challenging to get that trajectory and to even reduce it. And so unless they can be easily reduced with traction or extension on X-ray, they're generally not good candidates for C2 odontoid screw. All right, so just to review again, so this is our patient here, has that right side of pars fracture through the foramen, has a type 2 dens fracture. And so what are the operative options? Let's see, we can bump this up to Alex Schuper.
So I think given the imaging and her pretty significant symptoms, I think it's out of the question to pursue non-operative management. So for the reasons you mentioned, she's not a candidate for anterior leg screw. So I think posterior is really your only feasible option. Given the fact that she already has a C2 T2 construct, I think most people would go with just extending up to C1. I don't think you have to do an OC fusion for her. It doesn't look like she has O1 instability just based on her CT and MRI. So I would extend to C1. I won't get into the nuances of construct formation, but yeah, I think just generally extending to C1, and then because of the C1 compression, I would also favor decompressing at C1-2 at least.
The only thing I would say is that these screws T1 and T2 are pseudoed, and so so very close. We initially planned for C1 T3 reinstrumentation and fusion, and C1-2 laminectomy, like you had suggested. However, intraoperatively, Alex, you see this C2. This is not a C2 T2, obviously, but just pretend like it is a full C2 T2. You see this intraoperatively. You dissected it all out. However, you find out that once you take this patient in the OR, category 1, she's weak, and you open up and you see this, which is that the caps and the screws and the cross connector that's there are proprietary to a single instrumentation company, and they're not available at your hospital. And so what are your options now? You can't take these screws out. And how are you gonna manage that now?
Yeah, so I would still put my C1 screws in. You have a couple options so you'd have to put in marrying rods, and then you could connect them to the original construct. I would still favor, I guess it's tricky if you have to replace T1, you have to find a bailout option in terms of getting the caps off. I mean, you could do everything from like drilling them out, not ideal, obviously, and then helicoptering the screws out, bending the rods out of place, obviously, to do that. So you can put in marrying rods, make it a 4-rod construct, and then so
tell me where exactly you would put your rods. And where do you put your screws? Yeah,
so
because this actually happened. This happened to us.
Yeah, I put my new screws at C1. I'd eventually get T1, T2 out, replace those as well as extend down to T3, and then
how are you going to get T1 and T2 out with that? Because the caps, the drivers are pentanol drivers, and you don't have them.
Yeah, I mean, I guess the options you could try to like drill out the cap. Not ideal, but
even if you could drill out the cap, and you could even bend out the rod.
Bend out the rod and then helicopter the.
How you gonna helicopter the screws out? You just broke the caps off.
Yeah.
so this is the exact problem that I ran into intraoperatively. We opened up to a different instrumentation company that has a proprietary screwdriver for the screws, and a different proprietary driver for the caps, and a different proprietary driver for the crosslink. So it was all, so we didn't have access to any of that. And so this is what we end up finding. So this is the this is the pre-op X-ray from an outpatient setting. And so what we ended up doing, well, we took a carbide drill bit and we cut the rods right where you see the red marks here. So I cut the rod here, cut the rod here, here. And what that did was that isolated each of the screws with the rod still on it. So I could grab the rod and then helicopter it out. So that way I don't have to remove the caps and I don't need any proprietary drivers. So I helicoptered those screws out. Then we placed new pedicle screws from T2 to T4, and we skipped T1. And due to the anterior displacement of C1, we had to take both C2 nerve roots in order to put C1 screws in. And we slightly sunk those screws to be able to pull back on them later to be able to reduce her. And then, like you said, we placed two satellite rods from T4, and we went up to T2. We bent it out of the way and went around the outside rod and then connected it to C1, and then used lateral connectors and cross connectors to marry the four rods. So pretty close, but this really did happen to us intraoperatively. Like I said, we weren't able to remove this crosslink because they have proprietary drivers and the caps also. And so here's the post-op CT cervical spine. We were able to get into the C1-2 joint here, and you can see that we packed it with bone graft. Since the C2 nerve root is out of the way, it's much easier to do that once you take the bilateral C2 nerve roots. And then we were able to pull back on that slightly sunken C1 screw, just a few millimeters, and we were able to pull it back and marry it to the outside rods. You can see we got a good reduction of C2. And so this is kind of what the Frankenstein construct you end up with when that happens is the T1 screws are out. We bent the rod sort of laterally out of the way and around the outside rod, inside rod, and then connected it to C1 and married those two rods with, you see these rod to rod connectors here, and then these rod to rod connectors here, and then with cross links above. So, so this is a pretty challenging case because you don't really know what you're getting yourself into until you really go intraoperatively and you're like, oh, I can't pull those screws out. She did well postoperatively. She regained her leg function to 4 out of 5, and then she went to rehab. All right, so our next case is a 38-year-old male, history of alcohol use, was intoxicated and jumped a fence 7 feet high, and he fell on his back. He was able to ambulate home. However, he came in with severe back pain, progressive weakness, and urinary retention. Diffusely was 4 out of 5 bilateral lowers, and insert a Foley in the ED and got a liter out. All right, we'll go back down to our interns. Let's see, Chi, can you read this CAT scan for us?
Sure. So we're looking at the sagittal view of the C2 lumbar spine. And we can see that at the L1 level, looks like there is a fracture that extends. I don't see a retropulse fragment into the canal. But it involves the entire vertebral body. So at least the anterior middle column are involved. Mm-hmm. I think there might be a fracture potentially through the posterior ligament complex as well.
Yeah, very good. All right, so just like you described, there's a burst fracture of L1, and which extends through the facet here. You see this facet fracture on the right. There's also a facet fracture on the there's actually a pars fracture on the left, and then that fracture line goes through and through the PLC through the spinous process a level above. So correct. So then, what is your TLIC score? Emily.
Yeah, so first looking at morphology, I think this is probably a compression. Oh, sorry, a burst morphology rather. So that's a 2 for that first part. And then we were just saying how we suspect that the PLC integrity is not intact. So that's a 2 as well. And then neurological status, we were saying he has the urinary retention. But I think the exam, he said it was still, he was having bilateral extremity weakness. What was it again? It was like 4, was it?
Yeah.
4, okay. So it's not a complete cord, but maybe an incomplete. So I'd give it a 3.
Okay, pretty close. I think you're right, actually. So I gave him a burst fracture 2, injured PLC 3, and caught equina 3, total of 8. But I think actually you're right. I think this is a suspected PLC. But so yeah, so this is the TLIC score. It's divided into morphology, the integrity of the posterior ligament is complex, and neurologic status. And something between 0 and 3 is going to be non-surgical bracing or bed rest or just the pain control. A 4 is going to be surgeon's choice, whether they want to take it to the OR or not. And greater than 4 is always going to be surgical. Yeah, I agree. Maybe suspect, maybe a 2. Either way, he would either be a 7 or an 8, which is indication to operate. And so do you want any other imaging before we go to the OR?
Yeah, so especially for the PLC, we could get an MRI.
Okay, what sequences do you want to see?
Yeah, I want to see T2 sagittal in particular.
What else? What sequences are you going to want to look at for edema in the posterior ligamentous complex?
I'm not sure.
It's going to be a stir sequence. So here's the T2 here, and here's a stir signal here. I didn't give you the best cut in the world, but there was stir signal through the ligament here. All right, so let's bump it up to Brandon. What is your operative plan? Since we know going to the OR, TLIX is greater than 4. What do you want to do for him? And you see that there's cord compression or compression of the cauda equina here. There is some mild retropulsion of that fragment.
So for this patient, I'd want to primarily decompress the cord as well as offer stabilization. I think for levels, L1 is kind of at a transitional level, so doing likely 2 up, 2 down. So you could do T11 to L3 instrument fusion, as well as a decompression at the bilateral decompression at the L1 level, looking to get a reduction of the fracture and decompress the canal.
All right, great. Would you put a screw in at L1 or no?
Do we have any axial cuts?
Sorry, no, I don't. Good question. Yeah. There's some mild.
Probably not, because I think the fracture line extends through the pedicles, so you may not be able to get any purchase there.
Mm-hmm. All right, so our operative plan was to do a T10 to L3, 2 up, 2 down, like you said, L1, 2 or just L1 laminectomy, and a kyphoplasty at L1. So how do we achieve that? What we did was we put a cannulated screw at L1. So it's a screw that has a cannulation down the middle where you're at, and the tip of the screw has multiple perforations where you can inject cement through. And so that's what we did here. So I actually prefer to put in screws through a fractured vertebral body. It often holds it stable and oftentimes reduces it on its own, because what you're doing when you're putting in that screw is you're going to push that fragment back towards the interior body. And so you can see I didn't do any transpedicular decompression here. All we did was put the screw in, and the screw itself pushed that fragment back in, and then we injected cement to fill that dead space and to prevent it from further collapsing, and then did a fusion. Patient didn't have any cord compression. We could consider doing this MIS percutaneously, either navigated or just through fluoro, and just putting a rod on. But however, because he needed the open decompression, we had to do this open. So he did well postoperatively. He regained full strength. We put him on bladder rest until post-op day 3. And then he passed trial void, and then he was discharged home. You can see our construct here. You can see the cement that's sitting in that level. And then he was discharged home. All right, nice. So this is my third case. Our third case, so this is MU. This is a 56-year-old male, history of neurofibromatosis 1, who underwent I think it's actually T10, I'm sorry, T10 to S1 posterior instrumentation fusion and intradural tumor resections. This is back in 2013 at the outside hospital, and presented with severe low back pain, bilateral foot drops, right worse than left. And on exam, is approximately he's 4 out of 5, but distally in the left side, he's 3 out of 5, and the right side, distally, he's 0s. All right, so this is MRI lumbar spine. You can see that they did some intradural exploration and resection of tumor. He had NF, so likely out towards foramen. And you can see that he has a fusion mass here between L2, 3, 4, 5, and the posterior lateral. He was fused also. So here's a CT lumbar showing, actually let's, Noah, can you read the CT lumbar for us? The cuts are a little strange because he's very coronally imbalanced.
Yeah, so just go from left to right here. Looking at the top, a lot of the screws more cranially seem like they're backed out a little bit, especially going down towards the middle of the construct. Can't really appreciate any definitive haloing on the panel on the far left. Going to the middle, I can definitely appreciate some haloing there. Looks like at least the L4 and L5 screws are backing out. And I think that's further redemonstrated on the panel on the far right. Certainly the S1 screw is also backing out as well.
Yeah, great. So yeah, so he has some proximal junctional failure, or kyphosis rather, and we're going to operate on him, so consider failure. And has haloing of osteoarthrosis of those screws, and that's construct down at all the way down to S1. But you can see that he does have a solid fusion mass from L3 to 5. So these are his midline cuts. You can see that the screws are not in ideal placement. On the left side, this is T11, T12, and this is L5 here, which is probably causing most of this drop. So before doing any deformity correction, what measurements should you know? You have to know all these measurements prior to attempting any deformity correction. You have to know everything in the sagittal plane, the vertical, the SVA, pulmonary lordosis, sacral slope, pelvic incidence, pelvic tilt. And then we also always have to check the coronal balance as well. So coronal decompensation, we've gone over this a few times, but how do we calculate it? Basically the distance between the C7 plumb line and the central sacral vertical line. And negative would be towards the left, positive towards the right. And so basically you drop a plumb line from C7 and you drop another line up from the center of S1, and that distance is going to give you your coronal plane decompensation. SVA, you drop a plumb line from C7, and then you take the distance between the posterior superior aspect of S1, and that gives you your SVA. And a normal SVA should be right around 2.5 to 4 centimeters. Plus minus. Positive would be towards anterior, and the negative would be towards posterior. Pelvic incidence, this is calculated between a line drawn between the midpoint of sacral end plate to the center of the bicoxfemoral axis, and then a line perpendicular from that sacral slope. And so you can see here, you basically draw a line along the sacral end plate, and you draw a line from the head of the femur up to that, and then a perpendicular line from the sacral slope. And can you change PI? During puberty, PI is generally considered, following puberty, sorry, PI is considered a fixed morphologic parameter, but I'll show you a case at the end where some deformity surgeons have done S1 and S2 PSOs in order to change the PI. And the normal range for the PI is going to be 45 to 65 degrees. So keep that in mind for the case at the end. And so pelvic tilt is measured by the angle drawn, the angle subtended by a line drawn from the midpoint of the sacral end plate. So basically you take the sacral end plate, you draw a line down to the head of the femur and you draw a plumb line that goes straight up, and that gives you your pelvic tilt. And that should be between 0 and 20 degrees. The sacral slope, like I already mentioned before, it's an angle drawn along the sacral end plate and a horizontal line, which then gives you your sacral slope. And this should be between 30 to 45 degrees. So lumbar lordosis is the angle measured between the superior end plate of S1 and the superior end plate of L1. And that normally should be about 20 to 45 degrees, but that really varies depending on the patient's PI and their compensation. So these are his standing scoli films. You can see that he's coronally imbalanced here. He's sagittally imbalanced also, fused and flat back, and you can see that there's a rod fracture here as well. Actually, if you look at the contralateral side, it's really hard to see, but you can see the rod makes this very, very kind of subtle acute turn, and the rod's actually fractured there also. I think that's where they married the two X-rays, so it's a little bit harder to see. So his PI is 46. His lumbar lordosis was actually negative 10 degrees, meaning he's kyphotic, he's forward. And his PILL without the mismatch is 56 degrees, and the mismatch was about 47 degrees, and his SVA was about 21 centimeters, and his coronal imbalance was about 3 centimeters to the left. So pretty imbalanced. Let's see. Matt, what are your options for surgery?
Yeah, I mean, I think caudally, you probably have to go down the pelvis. Cranially, have that T11.
He's already fused at T10.
10?
Yeah, sorry, I
up
counted.
to like T6 or something, I would think. And then you'll have to do some posterior column osteotomies. You have to revise all the screws that you pointed out are.
So this is your patient.
So
this is your patient. What's your exact operative plan for this patient? Let me actually show you the X-rays. Might be easier.
I think in general it's T6 to pelvis. I'm not quite sure how you'd want to get the coronal, sagittal alignment. I mean, do a bunch of Smith-Peterson osteotomies and slowly sort of bring him back. I don't know if that's the most efficient way, but you could probably do a PSO, in the lower thoracic, do a kickstand rod. Got to push and fix that coronal imbalance. But yeah,
nice, super close. So I wouldn't stop at T6. That's the apex of the thoracic curve. Usually you want to go just past it or just under it. There's been studies that show that stopping at the thoracic apex tends to lead to higher rates of PJK. And so we decided to opt to do a T4 to pelvis, past the thoracic curve, and go down the pelvis, do a kickstand rod from the left, like you said, in order to push him back towards the right. And we did a asymmetric PSO at L4. And the reason why we chose L4 is if you can see, if we go all the way back, you see how he's fused from L3, 4, 5. The obvious choice here would be to break this fusion mass and then crunch him down at PSO this level. So at L4. So our goal of surgery, I shouldn't have scrolled that far. I had another slide. So we opted to do a T4 to pelvis revision, instrumentation fusion, and an L4 extended PSO. And our goal of surgery is this. So to get about 45 degrees of correction, come towards the bottom end of the pedicle, and then make a cut all the way to the ALL, and then make another cut with the osteotome straight down. And then if we got 45 degrees of correction, then we can reduce our mismatch of 46 degrees or so. All right, so then Schwab grades we talk about quite often, but this is for deformity correction. Grade 1 is a partial fastectomy. Grade 2 is a complete fastectomy. Grade 3 is a PSO or pedicle subtraction osteotomy. A grade 4 is an extended PSO where you remove the disc space above or below. Schwab grade 5 is a vertebrectomy, a complete removal of the disc above and below, and the entire vertebral body. And then grade 6 would be multi-level. And so what do I mean by asymmetric PSO? It's where it's used to correct coronal plane deformities usually. It's usually used in children who have huge omega type curves or that doesn't need a VCR maybe. And it can involve one or both pedicles. So this is the cuts that we planned, meaning that we want to take a much larger PSO bite on the right than the left. In order to be able, when we close the PSO, we'll close them asymmetrically so that we could bring them back over to the left. And so this is our post-op CT, and you can see that we got exactly the amount of correction that we wanted, and then we extended him up to T4. And even though this is a supine film, you can see that he already looks like he's in better alignment. And this is his post-op Scoli film. Like where we did use that kickstand rod like you suggested, and we used that to push him back over to the left. And we did the asymmetric PSO. We removed both pedicles, but made a much larger cut on the right in order to pull him back over to the left. And you can see that we were able to get a good sagittal correction using that extended PSO. And I just highlighted that kickstand rod. So preoperatively, his PI is 46. That didn't change. He was negative 10 degrees kyphotic. Postoperative, he's positive. He's 40 degrees lordotic. So we got about 45 degrees like we thought. And the PILL mismatch now about 6 degrees, or PILL without the mismatch, about 6 degrees. And his mismatch, he's now balanced. And the C7 SPA is about 1 centimeter. And his coronal imbalance, we took that down from -3 to about -1 centimeter. So he did well postoperatively. His right foot drop did improve only to about 2 out of 5. It had been since 2013, so he's going to need quite a lot of rehab. So he went to rehab and he's doing well. And so our last case is a really interesting one. So this is a 33-year-old female. She had a history of motor vehicle accident and prior lumbar fusion at outside hospital and presented with acute onset back pain and worsening urinary incontinence. And so the right lower extremity at the time was 4 out of 5 throughout. Left side was full strength, and she had increased sensation on the right lower extremity. And this is her CT lumbar. Let's go down to Emily. Can you read this for us? Oh, does she allow it? Okay. Chi, you want to take this?
Sure. So we're looking at the sagittal view of the CT lumbar spine. And we can see that it looks like she has a fusion from L4 down to S1. And from looking at the rightmost panel, looks like I don't see any haloing around the screws. But then at the S1 screw, looks like potentially it might have been there's a fracture line. It looks like in a posterior aspect of the screw.
Okay, all right. So you do see some haloing. I'm sure I throw some of the S1 screw here, and then you see that in the middle cut they probably did a peak T-lift because it's not really opaque. And then here you can see the tulip head is not really attached to S1 here. And so what does that tell you that she's doing to the construct? She's probably putting a lot of strain on that last screw, a lot of strain on the construct. And you have to start thinking about why. And you can see that she has a very, very, very angled sacral slope and a hyperlordotic lordosis in order to compensate for that. So here's her MRI, which shows that she does have some fecal sac compression at L3 above. And here's her lumbar x-ray. This is her standing x-rays. And you can see now, even when she stands, she pulls that screw even higher away from, that tulip head away from that broken screw. And you can see, again, still she has a super hyperlordotic type curve in the lumbar spine. And so I'll just give you the spinal pelvic parameters. She's actually over 100 degrees in terms of her pelvic incidence, and her lumbar lordosis is about 67 degrees, and her sagittal SVA, so C7 SVA is about 16 centimeters forward. So her PI is 101, lumbar lordosis is 67, her PI-LL mismatch is about 34, sorry, not mismatch, but the difference is about 34 degrees minus the 9 degrees for compensation. So then that would give you about 25 degrees of correction that you would need. So then what are your operative options, Abi?
Can you go back to the scan? Great. Oh yeah, so it looks like she is becoming there's hyperlordosis. So and in terms of operative options, you need to actually decrease the amount of lordosis to be able to kind of pull her, to be able to fix the mismatch as well as res screw. So one of the options is obviously you have to be able to extend the fusion to be able to get a purchase at the inferior part of the construct. And the goal of the surgery is to extend the fusion. I would extend at least 3 levels superiorly to be able to pull her back. Down, I would go down
Hold
to
on.
either. I would
Abi,
go down to pelvis.
you said you want to decrease the lumbar lordosis, but you're also saying you want to pull her back more. So what do you exactly want to do in this case?
Yeah, so I do want to pull her back more, but I want to pull her back from the acute most angle or for lumbar lordosis, right? So I would do a fascicectomy at 5, 4, 3, 2. I would do a fascicectomy at 2, 3, 3, 4. I would extend the fusion up to maybe T11 to T10, and then pull the patient back. Basically pull the spine to the rod, as well as extend the fusion down to pelvis. So I'll put my screws in first, put the rods in.
So tell me, so this is your patient. You're about to go to the operating room. You had the whole discussion. What's your operative plan? What are you planning on doing in the OR?
In the OR, I will start by revising the hardware, putting down the pelvic screw, and then I will put pilot holes and screws all the way up to T10. And then I will remove the joints at L1, L2, L2, L3 probably, maybe also 3, 4. After removing the joint, there's going to be increased mobility to be able to decrease the lordosis. So instead of pulling the patient back from the top of the construct, you basically start from the bottommost part of the new construct. So in this case, you start from the L3, you pull L3 back, and you work your way superiorly to bring spine towards the rod. So you keep the rod at a less of an angle. You keep it more flatter, and as you pull the spine back to the rod, you should be able to at least partially correct it.
Okay.
And you can also use,
I think this is the first time where I did, where we suggested a smaller surgery than what you suggested. So, so think about what our goals of surgery. We need to balance her somehow, right? We need to pull her back. And so how are we going to do that? We can do that either through, like you said, PSO or PCOs or PSOs. But what's one way where you can balance her without giving her 100 degrees of lumbar lordosis? I kind of hinted at it before, changing the PI. So what we suggested doing was doing an L2 to pelvis, instrumentation and fusion, doing an S1 PSO, and doing a L3 to S2 laminectomies. So our goal of surgery then is to wedge this out and get about 40 degrees of correction down at S1 and do the PSO at S1 and reduce her, or artificially reduce her pelvic incidence by 30, 34, 35 degrees and somewhat preserving her lumbar lordosis in order to keep her balanced. Dr. Jenkins said, what about her morbid obesity? Yes, I agree with you, Dr. Jenkins. I think, part of the problem is definitely her obesity. However, I've learned over the years with Dr. Margettis and other attendings that it's with this pain generators, it's often very difficult to ask them to lose weight or significant amount of weight without gastric bypass or things like that prior to surgery. And you could see she already had a hip replacement. But I do agree with you, Dr. Jenkins, that weight loss would be one of the first things we could ask her to do. So our goal of surgery, like I said, was to do an S1 PSO and try to flatten her by 34 degrees, 35 degrees or so. And so the S1 pedicles can be resected. However, in order to close the PSO at S1, you also have to resect the bilateral sacroala partially. So you have to do your PSO and also have to extend that PSO through the sacroala bilaterally. Otherwise, when you close the PSO, you're going to trap the L4 and L5 nerve roots, and you're going to get loss of motors intraoperatively. And bilateral S2AI screws are placed in order to get sacral fixation as well as pelvic fixation. Now that we remove the S1 pedicle, there's no more S1 screw there anymore. And then along with bilateral pelvic bolts as well. And so this is the construct that we ended up coming up with postoperatively. You can see that basically we pulled her entire pelvis, her entire spine over the new sacral slope, or the new sacrum that we made for her by doing the sacral osteotomies. And here's her post-op X-ray. As you can see before, her screws were almost pointing straight down, but now they're pointing almost in a good location, a good fashion. And you can see that because we had to remove the S1 pedicles, we had to place four pelvic bolts in order to, or 2 pelvic bolts and 2 S2AI screws in order to hold this construct still. And here's our pre and post-op X-ray. You see this is a standing. These are both standing X-rays. On the left, you see this is the pre-op where you can see the screws are the L5 and L4 screws are almost pointing straight down, versus on the new standing X-rays, they're pointing more horizontally, and her new sacral slope is changed about 35 degrees. And so we ended up changing the PI from 101 degrees to 65 degrees. We actually decreased her lordosis from 67 degrees to 54 degrees, which is what she really needed. She was compensating by hyperlordosing her lumbar spine, and her PI-LL mismatch of 25 degrees went to about 1 degree. And so she did very well postoperatively. Her urinary retention resolved, and she went to rehab. She actually returned once before. We got new X-rays, and it looked very good. And so that's my last case. So I'd like to thank Dr. Betterson, Dr. Srivastawa, Kamako, our leadership for giving me the opportunity the last 6 months to do this spine fellowship. And then I'd like to thank all of our spine faculty, but specifically these 4 attendings that used their cases throughout my 6 months to show during the spine conference. Thank you.
Frank, I want to recognize you for a wildly successful spine fellowship experience that really everyone on the service, attendings and residents, benefited from. You really elevated the level of care and the teaching on our service, and I thank you for that. And I think some of these cases show how complex the decision making is, and if you're a resident, I wouldn't feel bad if you can't get the plan right away, because sometimes we talk for hours on before the case and how to devise the best plan. So thank you again, and great case examples.
Yeah, and Frank, I just want to point out, in addition to what Dr. Chowdhury said, that this illustrates that we really, everyone here knew that we have a world-class spine division, And I think that your experience illustrates that it can really offer an exceptional training and educational experience. You should really highlight this for our applicants too, as they come through, so that they can appreciate what they can get here in the spine division.
Yeah, for sure. Yeah, I mean, I feel really fortunate to, to be a part of our, to be a resident here and train under everybody here in the spine department. So yeah, thank you.
Thanks, Frank.
So much money is going into and so much time is going into figuring out how to coil an aneurysm. But here we've got this other procedure that is much more common, and now we've got a potential treatment for it. So really, this paper laying out the argument for evaluating a new treatment process like this, a new treatment option like this, really also was a second catalyst. So we had a meta-analysis with some pretty good, pretty strong data that was convincing. And then we had the problem laid out very nicely in the literature by this paper and a few others. Let me take a step back to the anatomy for a second. This is from neuroangio.org, which is a site maintained by NYU. That's really an exceptional site if you're trying to dive into neuroanatomy or cerebrovascular anatomy. And it's a completely free and open site. And so this particular drawing I've shown in this conference before, and wanted to just highlight that the MMA is coming off the ECA, the external carotid artery. It's very easy to access. And because it's off the ECA, it's generally much safer to access and embolize than anything in the intracranial circulation. So the procedure has a much lower complication rate than other interventional procedures in which an intracranial embolization is common. This is a much safer procedure because the catheters are always, the end of the catheters and the action of the catheters are the ECA. It doesn't mean there can't be problems, but the problems are very rare. The problems happen from collaterals from the ECA to the intracranial circulation or nerves. And the biggest one to watch out for, the most feared complication in this procedure, but because we know about it and we understand the anatomy from accessing this artery for many other types of problems like fistulas for many, many years. And Dr. Berenstein is one of the world leaders in identifying the anatomy and discussing how procedures like this are supposed to be done. You have to move your catheter more distal than the collateralization point to the ophthalmic artery. And so this right here, S, is the ophthalmic artery, J is the middle meningeal artery, and L is the meningo-ophthalmic collateral. You have to assume this is always there. Early on, when people were discussing this procedure, they were not necessarily assuming this, and many times people got lucky. I've seen many embolizations from the early days, from 2019, 2020, not from our institution, but from others, where people were embolizing from here. And if there was a collateral, you would go to the ophthalmic. And so sometimes you can't see this. You have to assume it's always there, even if you can't see it. And you go past it and you get up very far into this branch and you get very far into this branch and you do what's called a super selective embolization. So now that has become a standard in MMA embolization. And now we know you absolutely have to get past that. And that's one of the procedural details that we've worked out very early on in applying this to MMA embolization. That's helped us to completely avoid this complication. This has never happened in our institution. There's another set of collaterals that come off from here. And these collaterals go to arteries that supply cranial nerves, specifically the facial nerve. And so if you embolize from here, embolisate can go to the facial nerve through here and cause a facial palsy, a peripheral facial palsy that's easy to identify on exam. So we know you can't embolize from here. You have to get out distally and do a super selective embolization. And so that keeps the procedural complication risk of this procedure very close to zero if you get out to there. Now, what's going on that embolization might help? And so I wanted to talk about the pathophysiology for a second here. This is one of the first papers on chronic subdural hematomas from Virchow himself from 1856, obviously in German. And this is hematomas of the dura mater. You don't need to speak German to translate that, or to translate this phrase here, which is how he described a chronic subdural hematoma as a pachymeningitis. And so back then, it was understood as an inflammatory condition rather than a blood clot. It wasn't even described here in this paper as a blood clot. It was described as a pachymeningitis. And so it really is a chronic inflammation that occurs, and it's that inflammation that is causing a proliferative process. So let me just point out a few of those proliferative processes that we're trying to target here. The anatomy of the membrane is there's this, we've all seen it, there's this very thick external membrane, and then there's this more gelatinous and layered internal membrane. And the things that are happening there are highly permeable capillaries from the dura, which is not shown here, to the external membrane, and without throughout the external membrane. There's also proliferation of the external membrane, and there's bleeding and blood throughout the internal membrane. And so this whole process is thought to be driven by these inflammatory components. And there's a balance, an ongoing give and take. There's ongoing leaky capillaries, membrane proliferation, and bleeding. And then there's ongoing uptake of that blood. And so if the balance is in favor of production of blood, it goes, there's a larger subdural that forms over time. If the balance is in favor of reabsorption, then it resorbs over time. So how do we shift that balance? Do we get an anti-inflammatory into this area, like a statin, or does the patient just take a statin? And maybe that helps the patient. We know actually from a trial in 2018 that the patient taking a statin does actually reverse this process more often than not, and does actually help that chronic subdural hematoma to go away faster and help the patient to recover from their symptoms faster. So that is level 1 data. And so we often evaluate patients with chronic subdural hematomas for a statin. Also, we now think from this data I've shown you that embolization of the MMA can shift this balance as well. And so what we're trying to figure out is, does it shift it as well as statins do? It appears from the preliminary data that it might even shift it better than statins do. Does it do it in exactly the same way so that they're not additive and maybe you're just replacing the function of a statin? We've got to figure that out. None of the trials have incorporated statins into the analysis in a way that answer is going to be discovered in this initial wave of trials. So it's going to be something that we need to figure out either from a post-hoc analysis or from additional studies in the future. One thing we've learned from getting up into the MMA so much is that the dura is highly vascular. There's not just a few branches, and anyone who cuts into dura knows that dura is bloody, and there's a highly proliferative vascular network. And we see this now when we embolize. So this is a glue embolization done by Sharam, in which you can see that this is extensively embolized. And so what you now know is that if you block off one vessel proximally, it's probably just going to collateralize through these dural networks here. So what we think and have hypothesized from now doing a bunch of these procedures is that you probably have to get the embolic material pretty far out to block the network itself rather than just proximally occlude. We don't know that proximally occluding is not enough. It might be enough to shift the balance, but we think that you can shift the balance more if you more diffusely embolize. And so then that begs the question of what's the best material to do that? What material can best get out there and block this whole network? And that's an area of debate. And then what's a metric of procedural success? If you just block off the artery proximally, have you succeeded? Or do you really have to get to the midline, or do you even have to get beyond midline? We've developed a scale that I'll show you in a little bit. And we've proposed that in our initial case series that we think there's some value to getting further out to midline and maybe even beyond midline to block collateralization from the other side. Here's the first 72 patients or so who underwent embolization in the first year that we were doing this procedure. So from January 19th, when that first patient was done, exactly 4 years ago, to about a year later, we looked at our first 72 patients who underwent this procedure. This is before the trials were activated. So all these patients were outside of trial in a registry. So we looked at 72 patients. 4 of them did not have complete records, and then 7 of them did not have NBCA used, which is what we were looking at in this particular study to develop the procedure with the use of that embolic material. And I'll talk about that in a little bit of detail. And so finally, we ended up with 61 patients. You can see a few details of the patients. Many of the patients were on antiplatelets. Many of them were on, some of them were on anticoagulation, and some of them got surgery, and some of them were medically managed and also got embolization. And so that then introduces the question of, is this a good procedure to do if a patient gets surgery, or is it a good procedure to do like giving a statin if a patient is just being medically managed? Does this procedure work better in one condition or the other? We think that it probably seems to work similarly. And so the trials are now evaluating both groups separately. And I'll show you the trials that are evaluating that. But in our experience, and in this particular paper, in this first initial experience, it doesn't seem like there's limitation to the effect of the procedure when patients undergo a procedure beforehand or when they're being primarily managed by middle meningeal artery embolization. By the way, you would never primarily manage a patient who's coming in with significant neurologic symptoms or has significant shifts and you're concerned about that patient. This is not something that's going to help that patient within days. It's more of a treatment that's going to help that patient within more than a few weeks or maybe even a few months. And so this is not an acute management for a patient who has a significant deficit. This is a adjunctive management in surgery for those situations, or a primary management for a patient who has no or minor symptoms, but a notable subdural. So here are some more details. A few of the procedures were done under general, but many of them were done under MAC. And so I note that to say that this procedure can be done fairly quickly, usually under 2 hours. And I believe the mean is around 1 hour. I don't think we have the time in this paper. Here we do. Fluoroscopy time, 45 minutes. Procedure time mean 91 minutes. So 1.5 hours on average for the procedure in our first 72. We've certainly gotten faster since those early days. And in this cohort, 3 patients required retreatment. So that was a retreatment rate of 5%, which is really very close to the data that was shown by that meta-analysis, where I'll just go right back to it for a second here so you can see that primarily. The recurrence rate in that meta-analysis I showed you, the recurrence rates were 5% or lower in this single center data. And so retrospective data. So we're seeing the same in our single center retrospective data. We're seeing 5% in this first 72 patients. And then when you look at the recurrence rate of non-embolized patients, it was a little higher in that group. We don't have that for our own group here, but we're just looking at the embolized patients. And so let me show you just one patient from that series there. And you can see that what we did here is you can see the embolic material starting in a super selective fashion. This is out into the MMA. Sometimes there's a little bit of reflux, but you can see that the majority of the embolisate here is out into the MMA. And then over time, you see the subdural go away on its own. Do these go away on their own by themselves? You can see this patient was primarily managed and didn't have a craniotomy. So in some cases, these do go away on their own, but in this particular patient, they had presented with some symptoms and had a subdural that was of a notable size, underwent the procedure, and then had resorption of that subdural subsequently. And so the timing here is, this is 1 month later here, where you have partial resolution, and this is 6 months later, where you have almost complete resolution with a little bit of residual. That timeline is very commonly what we're seeing. We're looking through all our patients and we're cataloging the timeline to give an average expected time course or resorption curve. But this is generally what we're seeing here, that kind of timeline. So conclusions from our own experience. MMA embolization appears to be safe. I forgot to mention that, but let's go back to the complications we experienced. We had one access site hematoma where the patient had a femoral access and had a hematoma that had to be managed, not with a procedure, but just with observation. We had no cranial nerve injuries. We had one event that we called thromboembolic, where the patient was immediately encephalopathic after the procedure and then returned to baseline after a few hours. So we noted this. We didn't know the cause of it. It was specifically an encephalopathy. Patient returned to baseline, did not have any long-term neurologic effects, but we noted that as a suspected thromboembolic event. So our complication rate was 4% overall, but our long-term permanent neurologic complication rate was 0. So it appears this procedure is safe. It may be safe. It may be effective. Let me go back to the effect comment. We had near resolution of nearly all of the subdural hematomas. Retreatment rate was 3, so 5%. So it appeared that there was some effect there with that as the primary outcome. However, there are additional details that we need to develop, such as how do we inject the material? Where do we inject it from? How far does it need to go? And we believe from this study that depth of embolic penetration may be a marker of procedural success. So from this paper, and from a few other papers in the field that were looking at a similar technique, we really mobilized in collaboration with Sarah Novus, a clinical trial that Sarah Novus is running, that Ansar Rai from West Virginia University and I are the PIs of. And there's a large scientific advisory board. And together we designed this trial and initiated it. And it's one of the 3 major trials. I'm going to go into detail about each of these trials because each of them is moving along, and they appear to be moving along at a similar timescale where they're all going to finish at the end of 2024 or the beginning, all going to finish within 2024. So Vault is a company that makes endovascular devices, and they have a trial named STEM that uses an embolic material called squid that is essentially the same embolic material as onyx. As onyx came off patent, this was developed. And you might recognize these names as the authors of that first review paper I showed you, David Theorella and Adam Arthur. They're looking entirely at medically managed chronic subdural hematomas, so patients who have not undergone surgery. And their start date was November of 2020. So they got going very quickly. And their total enrollment is 300. They have not completed enrollment, to my understanding. They're planning to complete the entire project in November of 2024. So getting there very quickly. Medtronic also initiated a trial around the same time with Jared Notman from Cornell and Jason Davies from University of Buffalo, using onyx, which is a liquid embolic, similar to squid. The name of that trial is Embolize, and they're looking at both medically managed and surgically managed chronic subdural. So if the patient undergoes surgery, they can have embolization, or if they're medically managed and don't undergo surgery, they can also happen to be randomized. And each of those outcomes is being looked at separately. They started around the same time, 2 days earlier actually, than the Vault study. And they're enrolling 600 patients because they have these 2 separate arms. And they expect to be completed with enrollment by May of 2024. The reason why these dates are important is because if one study completes their study and reaches their endpoint, that's going to change medical management and the standard of care. And when that happens, the other trials will probably have to halt, as happened with thrombectomy. So there's a little bit of a race to make sure everyone gets their patient allotment in before the other trials end. So let me go through a few more details there. The SQUID trial is looking at 310 patients, as I mentioned to you. These are the primary investigators. And so this patient inclusion set is 30 years old or more, patients who have a very good baseline. The hematoma has to be 1 centimeter or more, and it has to be a chronic subdural. It can have some acute components, but 50% or more have to be chronic. So that's a little bit different from other trials, but in this trial, 50% or more have to be chronic, and the patient's non-surgical. The patient has to present with 1 or more of the following symptoms: headache, cognitive decline, speech difficulty, aphasia, gait impairment, imbalance, or focal neurologic deficit, or seizure. So in this case, the neurosurgeon has to make a decision if the patient needs surgery or not. If the patient does not need surgery, even given these symptoms with a 1 centimeter subdural, then they can undergo this procedure. And this is the device that's being evaluated, or this is referred to as a device. It's a liquid embolic called SQUID, which is a non-adhesive embolic material that you inject into the artery, and it fills it and blocks it, but it doesn't stick to anything. It's not a glue. But for that reason, it's very easy to control as it goes forward. It's something that we use very commonly for arteriovenous malformations or dilated fistulas. Here are some details about the Embolize trial. This is 600 patients. As I mentioned, Jared Notman and Jason Davies, and they're looking at 2 separate arms, a control arm here compared to a, medically managed arm with a treatment arm where patients undergo embolization. Sorry, everything's right here. So here's a subdural evacuation without embolization. Here's a subdural evacuation with embolization. And here's observation with no evacuation. And here's observation with no evacuation, but with embolization. So two completely separate studies occurring embedded in this study to answer each of these questions. Does embolization help without surgery? And does embolization help in the setting of surgery? This is the what the embolic material looks like. It's not squid, but it's onyx. And then now I'm going to give a few details about the membrane trial, which is ongoing. And this is what our team has played a major role in developing. And so, like the embolized trial, we have a surgical arm and we have a non-surgical medical management arm, and each arm is randomized separately. The surgical arm is randomized to surgery plus embolization. And the way this works is the patient has to get the surgery first, then they get evaluated. So we didn't include the risk of the surgery in the outcome. The patient gets the surgery, then they can be randomized to embolization or no embolization. And so as you're performing a procedure, planning to perform a procedure, we like to know about that beforehand so that we can discuss with the family the possibility of enrollment after the procedure, as long as the patient continues to fit the enrollment criteria. And so this is something that everyone here knows and has been participating in, and has been really, really awesome in referring patients to this. And we're therefore the highest enroller in this study, and I'll show you some of those numbers. So thank you for that. And then patients who do not undergo surgery, this is actually more challenging to enroll in because there's less urgency here for this group. They can think about it. They can go home and think about if they want to participate in the study, or they can evaluate other centers if they want to do other studies. And so enrollment here is slower, but it's still moving pretty well. Patients are 18 to 90. So this has an upper age limit, unlike the details from the STEM trial I was showing you that had no upper age limit, but we're capping it at 90. As we know, those patients generally do worse overall if they're older. They have to have at least some component of the subdural has to be chronic. There can be some acute subdural, it can be an acute on chronic, but there has to be at least some chronic component. The non-medical arm has to have a midline shift of less than 5. So there can't be a significant midline shift, because then the patient might merit surgery. So this is a little bit of a safety for this cohort, making sure that the patient's not close to needing surgery before they get enrolled in the medical management cohort. But the hematoma has to be greater than 1 centimeter. So there's a sweet spot of patients who are eligible for this cohort where it's a Goldilocks hematoma. It has to be greater than 1 centimeter without significant shift more than 5. And after surgery, there has to be a CT performed within 36 hours prior to embolization that does not show worsening of midline shift or increased subdural after the surgery. So once we have this CT, we can then, that post-op CT, we can then enroll the patient as long as they continue to meet all the other criteria. Exclusion, if it's entirely an acute subdural, if the patient has previously had other surgeries or other burr holes or SEPs. By the way, SEPs patients are able to be enrolled in this study. So SEPs counts as an intervention. If a patient has a bilateral subdural, we have another one that might need to get treated. That patient's not eligible because that could muddy the waters and alter the outcome of the study. Patients who are significantly impaired are not eligible. So if they have a Glasgow Coma scale of 8 or lower, or less than 9, or also a Mark Walder assessment of greater than or equal to 3, which is a subdural hematoma patient assessment scale. If they have an underlying vascular lesion or other issue precipitating the subdural hematoma, those patients are also not eligible. And of course, if there's a carotid stent in place, the ECA is blocked, so you can't get up there. So that's an obvious one, but a good thing to write down, because maybe it's not immediately obvious when you're evaluating the patient. But if there's been a stent placed, you can't access that ECA to do the embolization. And then when you're in the procedure, if you see the ophthalmic artery very clearly, through an anastomotic connection, then that's considered too dangerous to move forward with the procedure. The primary endpoint of this study, similar to the other studies I showed you, is a composite. It's a residual or reaccumulation of the chronic subdural at 6 months as assessed by an independent core lab, or reoperation of the surgical procedure. So if the hematoma remains large or recurs after surgery, or the patient goes back for reoperation, it's a composite endpoint of how is the volume of the hematoma doing, or did the patient require reoperation? And that's generally how the FDA has been pushing for this procedure, a radiographic outcome combined with a clinical outcome. And we also included in the study as a secondary outcome the scale that we developed here, looking at either how distal is the embolisate embolizing. If there's no embolization, if no embolization is done, it's a 0. If you only ligate with coils proximally, that's a 1. If you get some penetration selectively, that's a 2. If you get all the way to midline, that's a 3. And if you get beyond midline, that's a 4. And so we expect that there might be some effect even with a 1, but we expect the effect to be stronger as you move along this scale. This is the embolic material we're using. It's NBCA, it's a glue. So this is adhesive. It's essentially, this has been around for more than 20 years for the treatment of arteriovenous malformations. It's the most long lasting approved embolisate. And some of the advantages are it's very fast. So that's why we're able to do the procedures regularly under MAC. It's generally something that perfuses very well. And so we're able to get regularly a good perfusion. We were able to get distal perfusion in more than 50% of patients in that patient cohort I showed you. And it is generally not painful to patients when this is injected, unlike the other embolic materials. So it can more easily be done under MAC because it's faster, it's less painful. You can give lidocaine to mitigate some of the pain associated with the other embolic materials, but this is generally not painful. And even with lidocaine, there's sometimes some pain with the other procedure. And so we're regularly able to do these procedures under MAC, and often they're same-day procedures where an outpatient will come in, have it done under MAC, and then leave after a few hours of observation only. So that makes it a very attractive, rapid procedure for a patient who has multiple comorbidities and might have a hard time with general anesthesia or might have a hard time with long procedures. Here's the current enrollment. This is as of yesterday. This is highlighted because this center enrolled a patient yesterday. So as you can see, Dr. Schwarr is our site PI. We have enrolled the highest number of patients in the study. So again, thanks to everyone on the call here for referring patients to the study. We've got 30, which is a high percentage of the total randomized already, which is 170. And you can see that we're pretty close to the halfway point, and we're on track for that 2024 May completion date. And it seems like that's going to get us in before the other studies finish. So even though we started later, we're enrolling faster. And then the last thing I'm going to talk about is a few other discoveries that have come along over the years as this procedure has been done. And this is a phenomenon that's really unique, not completely unique, but it's rare to see this, where you've got trials going on, but you've also got all these case series coming out where the procedure is iterating in parallel to the trials occurring. And that's because there's been widespread adoption of the procedure, even while it's in trial. And so that's something that permits continued development and evolution. It also permits improved proficiency by everyone performing the procedure. And so we have learned quite a bit over the last few years. And so I'm going to point out just 2 papers, not to torture everyone here, but I'm pointing out this one because it's a great paper, but it's also done by one of our pre-residency fellows, Mira Salih. So this came out just last month, looking at in JNS, looking at reduced recurrence of chronic subdural hematomas treated with open surgery followed by middle meningeal artery embolization compared to open surgery alone. So these are patients who underwent surgery that either had embolization or no embolization. This is a retrospective analysis of a large data set at Harvard. You can see Ogilvy here, where they were doing burr holes or craniotomy for quite a long time. And then they started doing embolization in addition to craniotomy. And so they did a propensity match to look at a propensity match comparison between this patients selected from this large group of patients who underwent surgery alone to the more recent, smaller data set of patients who underwent middle meningeal artery embolization after surgery. So the total open group was 345 patients over many years. And then the total recent MMA embo group was only 52. So overall, you can see that many of the patients came in with a GCS greater than 8. So only a few were less than or equal to 8. Many of the patients came in on antiplatelets or anticoagulation. And so that's one advantage of the procedure itself, is that you don't have to stop those things for the procedure, but you do need to stop it obviously for a surgery, and you'll often stop it for a surgery. Propensity score matching was done based on the following features: age, sex, hypertension, diabetes, MRS score and presentation, subdural hematoma thickness, whether acute or subacute components were present, and on post-procedure anticoagulation and antiplatelet use. So quite a few matching components here. And looking at a one-to-one match, they also looked at a many-to-one match, but looking at the one-to-one match that was performed, they found significance in a decreased rate of rebleeding or recurrence right here. And so I'll just point that out. That's a 7.7% rate in this propensity match of rebleeding or recurrence. So it's a little higher than what we saw in our own data set of 5%, but it's pretty close. It's in the same order of magnitude. And so in this data set, they saw 30.8% rebleeding recurrence in the surgery group. So that's a little bit on the higher side. It looks like it's a craniotomy associated rebleeding recurrence rate from the data we were looking at earlier. And it's about a 4-time decrease then in this particular propensity matched analysis. Looking at reintervention, so not just rebleeding recurrence, but the need for reintervention, we're looking at 4% compared to 23.1%. So quite a bit of a decrease here, more than 5 times decrease here in this, and that was statistically significant. And then also length of stay. So an interesting outcome from that group here. And then looking at their summary, they had the rates of recurrence were decreased here. That was statistically significant, and the overall reintervention as well. So another interesting fact coming out from the data, and that's made possible by the continued performance of the procedure, even while it's in trial. I want to show this paper because this looks at proficiency of the procedure, and this is the Barrow group looking at their initial 41 procedures back in 2020. So this was early on. People were looking at ways to make this procedure work better. And in this particular example, they were looking at whether they embolize one branch or both. Of course, we always try to embolize both, but sometimes you can't because one of the branches is too tortuous and you can't get out far enough into it. What we do now is we bail out by placing a coil proximally. The coil does not risk the distal anastomoses. The coil is not going to go into the ophthalmic. The coil stays put, and you can proximally ligate that through endovascular coiling without risking distal issues. But if you were to use the embolic material proximally, that might go distally and cause an issue. So that's why a coil is a good bailout. Here, they were not bailing out with coils. They were just using them primarily. And sometimes they were only doing one branch, or sometimes they were doing both. And what they found was, they found that in this data set of 41 patients, when they did both, they had a significantly, I'm sorry, that's the wrong one. Anyways, but just take my word for it. They had a statistically significant improvement in their rate of hematoma resolution when they embolized both. So that gave us a little bit of an example of similar to what we were talking about with the depth of penetration. Here, the more you embolize, the better patients seem to do with the rate of hematoma resorption. Oh yeah, so here it is. So, oh, sorry, I don't think, oh, anterior and posterior here, anterior or posterior early here. So the hematoma size was much smaller at the endpoint when both were embolized. Number of procedures with complete resolution, 76% here, 33% here. So when you embolize both, you seem to do a much better job reaching complete resolution of the hematoma in the 76% versus only 33% in that small group. Small numbers, and it's a retrospective analysis. This is the data we're going to be working with until we have completion of these trials in a few years. And so let's talk about the remaining questions, and then hopefully we can have a little bit of a discussion about this. Is MMA embolization effective at reducing the reoperation rate? We think there is. We have that meta-analysis. We have our own center data, and now we have a plethora of other center data, of which I only showed you 2 studies, but there are many, many coming out. And they're all showing kind of a similar range of a 5 times to 10 times decrease in reducing reoperation rates. What is how effective is it at reducing hematoma volume, and what is the reduction timeline? That's something we're learning as well. We're looking at that in our own data, and that was the primary outcome in the statin study. And so it does make sense to just look at a radiographic outcome, and we will get this information from the trials. Doesn't matter what embolization material you use. Maybe one trial will be positive, maybe the other trials will not be positive, and then we'll get an answer there that one works and the others don't. I think it's likely all 3 will be positive, and then in that case, what works better? It'll come down to how positive each one was. People will probably draw conclusions from that, even though you can't compare across trials. But hopefully we'll combine all the data from the trials, and we'll be able to do some analyses on that patient level data. Does the degree of embolic penetration matter? It does seem to, just from that one paper I showed you from the Barrow. We're looking at that in our own data. And then because the network collateralizes so much, do you have to embolize both sides? We feel strongly here you do, because we see strong collateralization over the top after you embolize one side. But not every center feels that. Most centers do not embolize both sides, actually. So that's another question. And there's so many more questions in this exciting field, and it's moving very, very quickly. So I'll stop there and taking questions. See if some of them might.
Chris, I wanted to ask you, so to your last point, is the difference in practice among the centers something that's going to be analyzed in the sub-analysis of this trial? Like, could that potentially help him?
It might be part of the sub-analysis planned. It might be part of the planned sub-analysis of the other trials, but it's not part of the planned sub-analysis of the membrane trial. There is a run-in set of cases where you have to demonstrate proficiency with the embolic material in other kinds of cases. I believe it's 5 cases have to be done with the embolic material without complications in other disease processes. And then you have to demonstrate as a center that you've done a small number of MMA embos with that embolic material without complications. And so there has to be some individual accreditation to participate in the study and embolize. And there also has to be training. You have to undergo active training in person with the model that the company has. So there are some initial ways to make sure people are trained up before they get going. But of course, perhaps expertise will play a role here. I suspect it probably will. Over time, I've gotten better when I'm doing it clearly I can see at getting the embolic material more distal. And it's really a 2-person procedure. We didn't get into the details, but one person is injecting D5W while the other person is injecting the glue. So the coordination of the 2 does matter. So the fellow level experience also matters. So it's a little bit complicated, but I'm sure that will be looked at in post-hoc analyses and will be a factor. Let's see if Shahram is on here to comment as well. He's been a very active embolizer.
Yeah, great summary, Chris. Excellent talk. Yeah, very, very exciting subject in our field in the recent years. Obviously, we are very comfortable with this technique that Chris presented, and we believe that it is it's safe, it's relatively fast, and perhaps very effective. So it's going to be very interesting to see what the result of the trials will show if one approach is superior to the other. But I'm afraid that it's going to be very difficult to show any superiority between the different approaches because they're going to be relatively close and it's going to need a very large sample size. But I think with what we know, the bottom line is if we can take down MMA permanently and extensively, we really decrease the chance of recurrence of subdural.
Ram. I see Hazem may have a hand up here. Let me bring him up.
Thanks, Chris. Yeah, definitely a very interesting procedure and advancements that we have been seeing with performing MMA embolization. Doing those cases also opened the portal and the opportunity to understand some of the otherwise unknown pathophysiologies that may be underlying some of those chronic subdurals. In our experience, we have done a large number of cases. A handful of those cases, we've noticed unusual findings in the baseline angiogram of those patients, including the presence of some shunting processes, dural AV fistulas that otherwise would have not been diagnosed or identified. The relationship between these dural AV fistulas and the index pathology, the chronic subdural itself, is still not very clear whether the fistula may have caused the chronic subdural and it represents a certain subset of patients that have a different pathophysiology, or whether, as some propose, such fistulas and such shunting channels may open because of the inflammatory changes that happen with chronic subdural is yet to be answered, but we definitely now have a different type of understanding of the pathophysiology in a selected number of patients.
Yeah, there's definitely a lot more to learn about it.
Is the next update going to be January for 2027?
Well, it's 4 years actually. So yeah, that's right.
Hopefully we'll have some data from the
then.
trials before then. Yeah. Well, this is great. Chris, do you want to, before we sign off, do you want to just reiterate what the potential indications are for referring a patient for the trial or trials, just so that everybody in the group knows?
If you have any question, you should notify anyone on our team. The fellow often will then activate the research team assessment. So all you have to do is basically call a consult for MMA Embo, and then the evaluation will automatically occur. But basically, if a patient is between 18 and 90, if there's only one subdural, if there's any component of it that seems chronic, and even whether you're planning to not do surgery and just observe, if you've got a patient in the ER who doesn't need surgery and you want nothing to do with that patient, feel free to refer that patient and we'll take over. So those are the main criteria. And then we'll dive deeper if you make a referral. Yeah, or was your hand already up?
No, I actually wanted to also kind of do a quick plug here for the visionary collaboration we had with technology that you, Chris, have led with recruitment for patients for the study. I think one of the elements that helped with the success of the rapid recruitment in the membrane trial was the collaboration with Viz.AI that is capable of identifying chronic subdural patients in its algorithms that work on all of the CAT scans obtained throughout our system. So I think the marriage with technology here to identify patients has really been a change in the in the field of trial recruitment. And as we see artificial intelligence able to detect more and more pathologies like aneurysms, strokes, and ICHs, we may be seeing an uptick in trial enrollments.
Yeah, that's a development that occurred mid-trial, and it has been really a game changer. It's given us a global view of every patient with a subdural in the healthcare system. When a subdural is discovered by the VIS algorithm within seconds of the scan, you know, anyone who has the app, and if you'd like it, just give me a message and I'll activate it for you. You can see the scan and scroll through it, and then you can see the volume of the subdural and the degree of midline shift, and all those measurements are given to you. So you know immediately if that patient appears to be eligible based on the radiographic criteria. So it's really been very helpful to give us, you know, quick assessment anytime a patient is found to have a subdural in the system.
It was great. Thank you, Chris. Thanks everyone for the discussion.
And also happy birthday to Chris Kellner.
Thanks a lot, guys.
Oh, happy birthday.
Bye. Have a nice day, everybody.